طرش.
يلا
شباب جاهزين؟
جاهزين دكتور.
أوكي.
يلا. أو مساء الخير جميعا، وأول شيء بدي أحكي إنه شكرا لكم على استضافتي، إني أعطيكم محاضرة. إن شاء الله إنه يعني أنا عندي قناعة إنه أنا بتعلم منكم أكثر ما أنتم بتتعلموا مني. فبس بدي أسأل أول شيء كل الشباب اللي حاضرين سواء أونلاين أو شخصيا، كلكم ميديسن صح؟ كلكم مقيمين باطني صحيح؟
أنا ميديسن.
كلكم انترنال ميديسن. طيب ممتاز. سؤال قبل ما أبدأ، أنتوا يعني you take care of patients with a stroke، ولا مين اللي take care of those patients؟ طيب ممتاز، يعني you diagnose and you treat، يعني
Yes.
inpatient. خلاص ممتاز. طيب أنا اسمي محمد غانم. حاليا أنا عملت I did residency في finished in 2011 neurology، بعدين عملت vascular neurology fellowship، بعدين عملت neuroendovascular surgery و interventional neurology fellowship. فبasically I'm a neuroendovascular interventionalist from a neurology background. اليوم بدي تكون يعني مرور سريع على ال neuroendovascular therapy for acute ischemic stroke. زي ما بنعرف إنه the treatment of stroke changed significantly in the last 20 years, starting from IV medication that we started to give in 1996, which is the IV alteplase or TPA, the same medication that was used used in myocardial infarction, زي ما بتعرفوا. With the years, the treatment of stroke changed significantly. It changed حتى from a disease that used to be no treatment to a disease that you can reverse the deficits. You can make a big change in patient's life. So today I will be it will be a summary and going through history and evidence of acute ischemic stroke treatment. أنا كنت assistant professor of neurology في University of Arizona، وإلي شهر تقريبا نقلت على مدينة هيوستن في تكساس لشغل جديد. I have nothing to disclose. وبعدين قبل ما أبدأ يعني feel free guys إنكم to interrupt و ask question. يعني I will leave you unmuted الشباب اللي in person. feel free to interrupt يعني just shout and say I have a question. Just a quick introduction about stroke, significance of stroke على population. كل هاي data is driven from US data. للأسف يعني I tried to find any data that calculate things in Palestine ولا في المنطقة العربية، بس للأسف ما في يعني solid data to support what's the magnitude of problem. بس في تقريبا 800,000 people experience stroke or recurrent stroke every year. There is very few people who are trained in stroke as a specialty. حتى there is few people who are interested in neurology in general. يعني إذا بتطلع على ساعتك every 40 seconds there is someone in the US who has a stroke. Imagine this number in the whole world. I think it will be either the same or even less seconds. On average, every 4 minutes, someone dies of a stroke in the United States. It is the number 5 leading cause of death in the US, and it is the number 1 leading cause of disability in the US. Disability يعني تتراوح ما بين you live with some numbness to a significant disability that you lose your job and you lose your productivity in the society. وهي هي المشكلة تبعت الستروك، إنه أنت تفقد قدرتك على بناء السوسايتي وإنك تكون productive ويكون عندك شغل وتشتغل. This is just a cause of death, breakdown of cause of death from cardiovascular diseases. And you can see in the stroke, is one of the major causes. It is a fact, and we cannot deny, the stroke is not a one-time disease. Out of the 800,000, في تقريبا 200,000 has a recurrent stroke. Well, I think those are the most important patients. The people who had a stroke and they had a recurrent stroke. لأنه زي ما كلنا بنعرف it is a preventable disease. The same thing with myocardial infarction and heart failure and so forth. Generally speaking, we have two major subtypes of stroke. We have ischemic stroke and we have hemorrhagic stroke. Ischemic stroke is 85% of the total stroke subtypes, and hemorrhagic stroke 15%. Generally speaking, بس يعني in general, the long-term outcome, if you compare hemorrhagic to ischemic stroke, hemorrhagic stroke has a better outcome long-term. المشكلة في hemorrhagic stroke, if it kills you at the beginning from increased intracranial pressure or brain herniation or brain insult. بس إذا كانت hemorrhage small, the long-term outcome compared to ischemic stroke is better in hemorrhagic stroke. It's just a scheme. The key of stroke treatment, believe it or not, is to recognize the stroke. It is a very sad statistics. If you look at the statistics in the US, only 20% of patients who has stroke, they come to the hospital within the treatment window. لأن احنا نعرف إن stroke treatment it is challenging for one reason, or one of the reasons, and it's time sensitive. So if you do not come within the time of treatment window, you're not going to get treated. There's a lot of pressure على society وعلى community to increase the awareness of stroke. أتوقع إنه المشكلة في بلادنا it's much more significant. إذا في أمريكا only 20% present within the time window، بجوز في منطقتنا العربية خصوصا في فلسطين they come even that number is much less. لأنه يعني كلنا بنعرف أهلنا وحبايبنا في فلسطين وفي المنطقة العربية بصحى الصبح مثلا أو بكون مثلا مع أهله بحكي لك عندي خدر في إيدي مش مشكلة بجوز نمت عليها ولا عصب ولا إشي، وكل اللي حواليه بيكونوا كل واحد منهم بيشتغل شغل دكتور، they always come late للأسف. بس there's a few symptoms that we should recognize as a healthcare worker, وفي symptoms that we can spread to the public to increase the awareness and to let them know this is how you spot a stroke. كالعادة as we all know, unilateral weakness, unilateral numbness, visual disturbances, vertigo, double vision, imbalance or incoordination. More specific medical terms, aphasia, which is inability to formulate your languages, neglect or the inability to recognize half of the world, confusion, behavioral abnormalities. بس احنا بما ان في عصر التكنولوجيا والواتساب والايموجي، يعني بشوف ان هذا اقرب ايموجي للستروك. واذا بنذكر الناس في three main symptoms of stroke, which is coming from the word fast, F-A-S-T, facial droop, for the F, A for the arm or leg weakness, S for speech problem, and T is for time, which is calling 911. 911 اللي هي في أمريكا، بس اللي هي الواحد يحكي مع الطوارئ أو يروح to the nearest emergency department. They modified those symptoms لأنه إذا بتطلع على الفاست does ignore the posterior circulation, which is the basilar artery, which is one of the tricky and dangerous stroke to have. يعني تقريبا 80 to 85% of patients with basilar occlusion, basilar artery occlusion, they die. يعني mortality rate is up to 80%. فهذول patients, if we can pick them up, we can significantly decrease the death and the morbidity mortality of that. عشان هيك ضافوا الBE على الفاست، فصارت B fast, just to add the balance and the eye, which is more specifically or more geared towards the posterior circulation. فإذا يعني هون في أمريكا for general public they try to educate the community about the be fast, how to be fast. What about the term mini stroke or TIA? بحكي لك أنا إجتني شبه stroke or stroke خفيفة. I think those terms are both used for one entity, which is the TIA, the transient ischemic attack. From its name, it's called transient ischemic attack. So by definition, there is no stroke done. I do not like the term mini stroke. I do believe we should call it TIA or transient ischemic attack. It is a significant problem لأنه في كثير ناس من اللي بيصير معهم TIA they will have a stroke which is about 15% of those patients. If we are smart, we should chase those or we should target those patients. And if you target them and you correct the risk factors, you can prevent a significant stroke in the future. وزي ما حكينا زي ما بنعرف TIA it's يعني basically a alarming sign. يعني يا إما بصير actual blockage in the blood vessel or our endogenous TPA works and lyses the clot, or it is a small stenosis that will show symptoms on patients from a hypotension or any other reasons. 15% might proceed to a true ischemic stroke. Stroke will occur within 90 days in 10% to 20% of patients with TIA. Now let's concentrate على ischemic stroke. عشان نحكي على hemorrhagic stroke نحكي عن ischemic stroke. Risk factor إذا بتجيب الريسك فاكتورز تبعت الهارت فيلير والischemic cardiac disease, it's basically the same with some added risk factors: hypertension, diabetes, smoking, high cholesterol, atrial fibrillation is one of the major risk factors of stroke, and the rest. بحب دائما أحكي عن السيكل سيل disease لأنها جزء more common في منطقتنا العربية. السيكل cell disease is one of the risk factors of ischemic stroke, which is one of the easy to prevent ischemic stroke out of all these risk factors, which is basically you target the hemoglobin S. You have to make it less than 30% at all time. عشان هيك يعني as a patient who deals with sickle cell crisis or sickle cell patients, if the hemoglobin S is more than 30%, start blood transfusion. This is what we do. This is the only stroke that we treat by hypertransfusion to make the hemoglobin S less than 30%. زي ما حكينا, ischemic stroke, believe it or not, it is a reversible disease and it is a treatment, it's a time dependent. خلينا نتفرج على هاي picture. So let's imagine إنه at time 0 you have a blockage in the blood vessels of the brain, and it just fast forward 1 second. So if you fast forward 1 second, بعد 1 second there is 32,000 neurons lost in 1 second after a blockage or interruption of blood supply to the brain. واحنا زي ما بنعرف من البيسك anatomy والنيورو anatomy في الميديكال سكول إنه the brain tissue are not reversible. You can recover by neuroplasticity, which is forming new pathways, but in general, neurons are not reversible. So you cannot reproduce neurons. فأنت في 1 second بتخسر هيك. Let's go forward 1 minute. About 1.9 million neurons you lose in 1 minute. If you go 1 hour, 120 million neurons, and your brain will age by 3.6 years. هاي بس في ساعة واحدة تأخير إنك to get the appropriate treatment. Imagine you come after 24 hours and so forth. The treatment of stroke, which is يعني صراحة دائما كنت أسأل هذا السؤال إنه how can we initiate a treatment plan or a treatment strategy in our country. It does start from the community and it does start from the pre-hospital care اللي هو الدفاع المدني. لأنه if we do not recognize it in the community, the patients will not come to the hospital. And the treatment is hospital based. مش انك تعطيه اسبرين وتستنى عليه، لانه بالعاده يعني لما يصيبك ستروك اذا بتعطي اسبرين وكانت hemorrhagic stroke you can make the things worse. فالتريتمنت is time sensitive. The key when you see patients in the emergency department is the time of onset of symptoms, of the first symptom. We do not go by the time of onset, we go by the last time the patient was seen normal and acting normal. وراح يعني the main reason why we do not go by the time of onset. خليني بس أوضحها بشكل سريع. أنا عارف إني بجوز ماشي بطيء في أولها بس راح نسرع في الآخر. يعني I really appreciate إذا عندكم أي سؤال وقفوني. الفكرة ليش we do not take the time of onset for a true fact. يعني there is something in the brain function which is the brain recognition of deficits, which is neglect. Neglect is a major thing in stroke. فإذا بيجيك مريض كان مثلا بيتفرج على التلفزيون له 3 ساعات وبعدين حاول المريض مثلا to move to stand up and the patient fell off. هون السؤال when did the symptoms start؟ هسه لو تحكي مع المريض بيحكي لك لا أنا كنت طبيعي بتفرج على التلفزيون وبس وقفت وقعت. Is this the time of onset that you have to time your TPA to? I think it's wrong for one reason. إذا كان المريض عنده right-sided hemispheric stroke and he was neglecting for the past 3 hours watching TV, he or she will never recognize that they have a stroke. They only will recognize them when they start moving. For example, this patient who was watching TV for 3 hours could have had the stroke the minute he or she started watching TV for 3 hours. وما كانش عنده awareness. He was neglecting or she was neglecting. And the minute they start to move, the patient fall. And the fall is not the 0 time stamp for TPA. It's when the patient was seen normal. فin this case, I will ask witnesses. بسأل مرته ولاده ما انتوا شفتوه بتحرك وبيمشي؟ ما انتوا شفتوه بيعمل إشي of any purpose مثلا طلع جاء اشترى شغله من برا او غير اوعيه او مثلا طلع في السياره. لانه if you are neglecting you're not going to be able to do all of these things. It's impossible to be having a stroke with weakness and neglect and you'll be able to do a purposeful function. عشان هيك يعني لازم تتاكدوا كثير من ال time of onset and it's not always a true time of onset. You should have the time last non-normal we call it. فتريتمنت stroke is 3 arms. بتخيل أغلب المرضى في مجتمعاتنا they are receiving the medical treatment, which is they have a stroke, they come after 24 hours, you give them aspirin or anticoagulation, physical therapy إذا بصح لهم physical therapy وبعدين بتشوف كيف الريكفري بيصير. But the two main treatment that can change significantly the outcome is the IV alteplase or the IV TPA and the endovascular clot removal or mechanical thrombectomy. زي ما نعرف before 1996 the treatment was limited وكانت بس تعطي aspirin تعطي heparin. كانت الناس تجرب تعطي heparin مرة ما تعطي aspirin مرة Plavix or clopidogrel ويجربوا يشوفوا شو بصير في الأطفال. بس in 1996 the FDA approved the use of IV alteplase for acute ischemic stroke. The initial approval was 3 hours from the last known normal, but after a few years, they extended the window to 4.5 hours, 4 ساعات ونص. And it was based on randomized double-blinded study that showed outcome. هاي بس يعني summary of the NINDS study that happened in 1996, which showed a significant change in outcome, favorable outcome, TPA compared to placebo at 3 months, 6 months, and 12 months. وهاي برضو المورتاليتي برضو لأنه واحدة من الكريتيسيزم of TPA إنه you are giving a strong medication and you might end up with a massive hemorrhage in the brain. Even that, the death percentage was less with TPA compared to placebo. فهو السؤال دائما إنه who's eligible for TPA؟ زي ما حكينا it's a time sensitive treatment, so 0 to 4.5 hours from last known normal. عشان هيك أنا حاططها في الكابيتال letter هون إنه it should be last known normal, not the time of onset. And the patient does not have contraindication, and we'll go over the contraindication. خلينا to frame our talk based على a case, a quick case. A patient, he's an elderly patient with all the recipe and risk factors for stroke, hypertension, hyperlipidemia, coronary artery disease. He came with acute onset of confusion, right facial droop, and right-sided weakness while eating lunch with his wife. فهاي this is probably one of the easiest cases لأنه the witness is with the patient. Probably the time of onset is exactly the last known normal. المريض كان بوكل مع مرته بعدين فجأة بطل يحكي. He could not move his right side. Arrived within 1 hour of symptom onset. Physical examination showed aphasia. The patient cannot talk, profound neglect, and left gaze deviation with right-sided flaccidity, so weakness, right arm, leg, and face. خلينا نسأل حالنا سؤال. At this moment, you have the patient, you did the exam, and you have the witnesses. What part of the history you need to know at this time? Do you need to know is the patient right-handed or left-handed? Do you need to know if the patient last known normal, time of onset, discovery of symptoms, antithrombotic use, and the use of antiplatelets? I think all of the above are important, but the two most important pieces are the last known normal and time of onset. In the background, you can still collect data about إذا المريض على Eliquis or Xarelto or warfarin, إذا المريض على aspirin or Plavix. بالعادة لما يجي code stroke, the people should rush, and next we get always vital signs. The blood pressure was 180 over 100. Patient was mildly agitated. Labs were sent, and EKG was not done, but the patient is in normal sinus rhythm. في شيء بنعمله which is a standardized examination for stroke patients. بعرفش إذا أنتوا بتعملوه as part of your evaluation in the emergency department, بس إحنا بنعمل what is recommended to be done is the NIH stroke scale. بتعرفوا شباب ال NIH stroke scale ولا ما بتعرفوه؟ ممتاز. فأنت إذا ما بتعرفوا this is a standardized scale و it reflects severity. بتسألني أنا رأيي الشخصي I do not care about the NIH score. يعني لما يحكوا معي المقيمين أو طبيب الطوارئ يحكي لي NIH 4 I do not care. يعني بحكي له okay that's good. It gives me a clue this is a severe stroke or not severe stroke. But what I'm really concerned about is what are the points that the patient get from this 4 points. For example, إذا بتحكي لي 4 points only for numbness and mild dysarthria and mild weakness, it's way different if you give me 4 due to weakness and aphasia. لأنه الaphasia means that it's the cortex or the cortical function is disturbed, and this is more likely is a large vessel occlusion or a big clot in the brain, صح? I would probably give TPA for someone with NIHS of 4, although يعني, I do not care about the how severe is the stroke. If the patient is eligible, just give TPA. بس في فرق بين إنه يكون المريض عنده mild numbness compared to aphasia. فلما حد يحكي لك ال NIH4 اسأله what was the points lost in the NIH of 4? Was it like more of aphasia ولا بس numbness؟ لأنه في فرق كبير. هذا مريض 26 points. So what's next? Would you give TPA now? Would you wait and get more blood test? Would you get more test and CT scan of the head? Do not panic, do nothing. The patient has no treatment option. What do you do, guys? CT head, ممتاز, مش ممتاز. That's great. So to rule out hemorrhagic stroke. CT scan is the first test to do. هسه بتسألكم generally speaking, إذا مريض إجا he's not on any medication, no prior significant past medical history. you did a CT scan. What's the second only test you need to do before giving TPA if the patient has a normal CT scan, no hemorrhage? You only need one blood test before you give TPA, which is
coagulation.
coagulation. حدا عنده رأي آخر؟
There is no previous history.
No, yes, no, exactly. No, that's the key. No previous history, no medication on board. You confirm that. نعم.
Yes, and if you started with TBA and test later on showed the coagulopathy, you stop it. But taking into account that most patients have no coagulopathy and the patient was not on anticoagulant, you proceed with TBA.
ممتاز. بس في one test you need to do صديقي, which is يعني بحكي لك ليش إذا بتعرفوا الجواب راح أحكي لكم الجواب طبعا. بس there's one test you need to do, which is a very quick test before you give TPA. And this is based on the first trial of TPA. بالعادة في الطوارئ أنتم دائما تطلبوه دائما. Finger stick, blood check, glucose check. لازم تعرف الجلوكوز تبع المريض for one reason. One of the most common mimics of stroke is hypoglycemia. Hyper or hypoglycemia. وبجد شفتوها كثير. بيجي الواحد السكر عنده 2 أو 3 بيجي deficits. بتعطيه D5 بتحسن على السريع. بروح كل deficits. Would that stop me from giving TPA؟ لا. بس مثلا إذا إجا مريض عنده جلوكوز 5 بعطيه D5 push. إذا ما تحسن within minutes I will proceed with TPA. فهمت علي؟ But this is one of the reversible diseases that you have to do and it's one of the guidelines. For the 2 tests you need to do, granted, as you said, no coagulopathy, no medication on board that you know of, CT scan and blood glucose. This is the only thing you need to do. هاي CT scan. شايفين إشي غريب؟ خلينا بس for the sake of time, there is no hemorrhage, there is no hypodensity seen, but there is a dense MCA sign, we call it dense MCA sign, which is a thick clot in the MCA on the left side. So what are our therapeutic options is TPA. This is the contraindication. يعني كلكم تعرفوها, بتقدر تحفظوها, بتقدر تحطوها في pocket card in your lab coat. But my advice إنه try to find a reason to give TPA rather than try to find a reason not to give TPA. يعني كثير من الناس بصير يسأل ويبحبش ويدور في الهيستوري وفي الكونترانديكيشن مشان بس يلاقي له سبب ما يعطيش TPA. TPA is a safe medication and it is the #1 treatment options for stroke and it change outcome. فأنا ما بصير أدور والله بجوز لا, بس يعني there is absolute contraindication, there is relative contraindication. The things that I always like to mention هذول underlined. إذا المريض عنده coagulopathy طلع على platelets نطلع على INR. إذا كانوا على low molecular weight heparin, I think عندكم بتسموه كليكسان within 24 hours last dose. وإذا كان المريض على direct antithrombin or factor 10A اللي هو Eliquis, Xarelto, Pradaxa, Rivaroxaban وهذول الشغلات لازم تكون last dose within 48 hours. But the rest, the major ones are hemorrhagic stroke, frank hypodensity on CT scan, severe head trauma within 3 months, and so forth. But يعني, my advice, try to find a reason to give TPA. In this case, they gave TPA, the patient did not improve. So what's the next treatment? هون بلشوا الكلينيشن يفكروا في reasons or other options for treatment. The drive was they looked at the data. There's a few facts about TPA. Although TPA is a thrombolytic, but it's only given for only 10 patients of ischemic stroke patients. They are eligible for TPA because it's time sensitive, يعني 4.5 hours. There's a risk of hemorrhage, as we said. وكمان اطلعوا على the bigger the clot, the less chance the TPA will work. وكمان the bigger the clot, the higher the mortality. For example, إذا كان عندك a clot in the internal carotid artery, the mortality rate of this stroke is up to 50%. إذا كانت في MCA up to 30%. Basilar artery, as we said, is 90 up to 90% mortality rate. And the fact that the TPA is not always effective. The bigger the clot, even there is a study that looked at the thickness of the clot. If the clot is more than 8 millimeter thickness, the chances of the TPA to work is less than this. النيورولوجيست بلشوا يطلعوا على الكارديولوجيست. إذا الكارديولوجيست they can go into the heart and remove clot by angioplasty or removing the actual clot, why not we cannot do it? يعني there is a big difference. لأنه بتعرف إحنا في الهارت we are dealing with muscle, والmuscle can tolerate ischemia compared to the brain. والfact إن the brain is not regenerated, it's irreversible damage. وكمان الريسك of hemorrhage يعني في الهارت risk of hemorrhage within the muscle it is there, but it's less riskier than the risk of hemorrhage in the brain. Other problem with stroke patients إنه recognition of symptoms. It's very easy in the society ولا في مجتمعاتنا إذا واحد حط إيده على صدره الشمال على جهة القلب, this is a heart attack. فالناس بتصير rushing him, بعطوه aspirin. يعني education within the community is well established and it's very easy to pick. وحتى على مستوانا إحنا as a healthcare professional, you need just chest pain, typical chest pain, EKG and troponin, صح? Or cardiac enzymes. So it's easy to identify, easy to diagnose. As a stroke, not all of them, but the scientists looked and حكوا خلينا نتفرج على stroke that we can easily pick on imaging, and it has a bad outcome despite TPA. يعني TPA بيشتغلش فيها. Clot can physically be removed like the same thing they do with the heart. They defined something we call large vessel occlusion, which is LVO. يعني راح تسمعوها هاي كثير هسه, LVO or emergent large vessel occlusion. And they defined this any occlusion in the ICA or internal carotid artery, or the major blood vessels in the circular fluids, MCA, PCA, or basilar occlusion. وطلع إنه those patients, if you restore flow, the outcome is higher. And if you do not restore flow, the outcome is bad. وبعدين اطلعوا إنه how can we measure the outcome? هل الأوتكم بده يكون cardiac function, heart function, ejection fraction? هون الأوتكم is based على modified Rankin score, which is a functional score after stroke recovery. It's basically a score from 0 to 6. 6 is not included in this picture لأنه 0 اللي هو أنا وأنت normal, وال6 اللي هو death. 1 is you recover completely and you go back to full function. 2, you have a mild symptoms, مثلا mild facial droop, mild numbness in the arm, but you still can walk, you can dress yourself, you can go and بتقدر تشتغل كمان إذا بدك تشتغل. 3 is moderate disability using a cane. 4 using a wheelchair, and 5 complete bedridden. يعني you need help with everything, changing diaper, feeding, and changing clothes. فالgood outcome that they concluded لازم يكون 0 to 2, which is يعني if you look at this it's pretty good, صح؟ يعني الواحد يصيب stroke وتعمل له treatment they end up with 0 to 2. This is a very good outcome. This is what they looked at. They looked at let's look at the large vessel occlusion and let's think of removing the clot mechanically. Can we do it? Yes. We took this from the cardiologist and we have a pathway to go through, and we can reach the brain through the blood vessels. أول trials إجوا هم 3 randomized trials published in the New England Journal of Medicine. فهذيك الفترة كنت أنا يعني بفكر أعمل endovascular fellowship, وكانت bad news during my residency لأن all of these 3 trials were a failure. Basically يعني to summarize, they concluded إنه the mechanical removal of clot in the brain was harmful and it was killing patients. And one of those trials were stopped prematurely due to fertility. يعني المرض كان يقتل المرضى. بس دائما الضربة اللي ما بتقتلك بتخليك أقوى، صح؟ واحنا دائما الclinician we do not give up very easily. Always when you fail a trial, look why you failed and try to learn. المشكله في المشاكل في هذول 3 trials انه they did not detect large vessel occlusion. يعني they did not image all patients. Basically, they took all patients who came with a stroke to the angio suite or to the cath lab, and they tried to do treatment. وحتى the treatment was not standardized. مرة كانوا يستخدموا intra-arterial TPA، يعطوا TPA في ال blood vessels. مرة كانوا يعطوا intra-arterial heparin. مرة كانوا يحاولوا يشتغلوا في equipment that's not really designed for the brain. Or they did not even exclude patients with large infarct. يعني كانوا يعملوا CT scan في big stroke already on CT scan. They took the patients. فكانت basically it was a bad design. وبرضه إذا بدك تشتغل على a good trial, you have to pick the right tool. Unfortunately, in those trials, they picked a very old tool that is not designed for brain clot removal. الديفايس اللي استخدموه اسمه Mercy device, which is the same. It's shown in this picture, which is basically زي الزنبرك. يعني. It's a coil, and it was used in the interventional radiology very often to retrieve foreign body. مثلا بيعملوا مثلا stent placement in the arm or leg, will stent مثلا displaced or a coil displaced. This is, they just go towards the stent, they start like spinning the coil, الزنبرك, and the coil will be tangled on the Mercy device, and they pull it out. بس الساينتست in 2013 راحوا على FDA حكوا لها إنه إذا هذا الديفايس we remove foreign body from or foreign object from the body, the clot is a foreign object in the brain, and we probably can remove the clot with this. بس يعني bottom line, it was a bad design. With time, they had new generation stent retrieval. This is how we remove the clot nowadays, with a stent retrieval. And now we have more devices. Aspiration, basically you just go and aspirate the clot in the brain with an aspiration device. For 2015, 2016, 5 randomized trials came. Only 2 of them completed to the end, and the last 3 were stopped prematurely, not for harmful reasons, but because the first 2 trials showed good outcome. فهاي كانت الصيحة في عالم الستروك treatment، إنه في عندك 5 randomized trial, all of them are positive, all of them showed good outcome with up to 80% good outcome with a modified Rankin score of 0 to 2. وكانت it was on the news in 2015. It is recommended. It's one of the standard treatment for stroke for large vessel occlusion. كلكم تعرفوا من أيام كلية الطب اللي هو number need to treat, which is the number I need to treat any patients with a specific medication to prove outcome in one patient. يعني مثلا إذا أنا معي medication في جيبتي I claim بدعي إنه هذا medication is effective for stroke. To show the effectiveness, I have to try it on less patients to show outcome. إذا أنا عندي دواء بدي أعالج فيه 1000 مريض مشان أشوف good outcome in one patient, this is probably not a good medication. But if you have a medication that if you use it on 2 or 3 patients, you show the outcome right away, this is a very powerful medication. خليني أورجيكم بعد هذول ال 5 trials, where is the mechanical thrombectomy compared to those very common diseases that we deal with in a daily life. Bariatric surgery, very common. تنعمل كثير في الأردن، كثير تنعمل في الضفة. Probably most of the time, unfortunately not indicated. هسه يعني إلها صيحة، حتى في أمريكا إلها صيحة، اللي هي obesity surgery. You have to treat up to 75-80% of patients to show outcome in one patient, which is the outcome designed for the trial. Aspirin for myocardial infarction. You need about 50 patients to treat with aspirin to show outcome in one patient, good outcome in one patient. A PCI, which is percutaneous cardiac catheterization intervention for MI. بتنعمل كثير. You need 20 patients to show outcome, to show a good outcome in one patient. You need to treat 20. Sepsis, lice, defibrillator for VFib. mechanical thrombectomy. The number to need to treat for mechanical thrombectomy for large vessel occlusion is only 2 patients. إذا بتطلع على كل treatment options in the history of medicine, mechanical thrombectomy is the most powerful and effective treatment in the history of medicine. من لما الطب أنشئ في العالم, mechanical thrombectomy until now is the most effective treatment that prove outcome with a minimum number need to treat of only 2. فنرجع للحالة تبعتنا. This is the CTA. So in order to see if the patient is eligible for thrombectomy, you need to do a CT angiogram to show the occlusion. And you have to prove that the patient has occlusion. And this is the left MCA occlusion. And this is the treatment that was offered for this patient. بس يعني very quick video. This is one of the techniques that we use. You go up with a small microwire and you go through the clot very slowly, introduce a very small microcatheter. And through that, you go with the stent, you open the stent. We wait 2 minutes until the stent swallow the clot. But then you arrest the flow and you pull the clot down. المريض NIH of 26, basically if that patient did not receive treatment, he will be ending up في البيت لا بتحرك إذا granted إنه ما صارش عنده brain herniation who died or he required a hemicraniectomy for brain swelling. The patient discharged home within 48 hours after that treatment. بس برضو, this treatment was approved in 2015 up to 6 hours of time of onset or the last known normal. That was based on the trials in 2015. فإذا بيجي مريض with large vessel occlusion, 0 to 6 hours with a CT angiogram showing a large vessel occlusion, which is like ICA occlusion, MCA occlusion, basilar, and so forth, they are eligible for treatment. But with time, we learned, some patients, they even benefit after the 6 hours. وهي was also studied in 2 big trials in 2018, Diffuse and Dawn trial. And basically those trials looked at patients after 6 hours. Or believe it or not, those trials came back positive. And nowadays, the mechanical thrombectomy for ischemic stroke for large vessel occlusion is indicated up to 24 hours of time of onset or last known normal. It is not only powerful, we also extended the time window. Instead of 4.5 hours for TPA, now it's 24 hours from the time of onset. بس هذا لا يعني إنه المريض يجي متأخر عادي. There's multiple studies showed that each minute counts, each hour counts. Each hour delay in mechanical thrombectomy, there is a 10% chance of worse outcome. فيعني still it is time sensitive, بس I think the benefit here لأنه في ناس بيفهموها إنه خلص 24 ساعة معناته المريض لو يجي 24 ساعة we can help. لا, المريض اللي بيجي 6 ساعات, it's different than 8 hours, it's different than 10 hours, it's different than 12 hours significantly. So why the brain can last longer than 6 hours? The concept of Dawn and Diffuse trial came from this fact, which is the collateral supply of the brain. هسه إذا عندك clot in the left MCA in the brain, يعني logic thinking لأنه the brains the arterial supply in the brain is end artery, the same arterial supply in the hand. So if you block the blood supply in the finger, the whole finger will go necrotic, صح? The same thing in the brain, but this is not true all the time in the brain. لأنه إذا عندك a clot, خلينا نرجع لها, not all the brain distal to the clot will die immediately. لأنه في عندنا concept of collaterals. فأنت إذا عندك clot like this, we do have the ACA, MCA collaterals. فال-ACA, the anterior cerebral artery, does supply the MCA in the watershed area, even beyond the watershed area. فإذا عندك clot in the brain, this area will be infarcted and irreversibly damaged. بس اللي بصير عنا إنه بصير في عنا something we call core and something we call penumbra. The penumbra is the tissue of the brain that is still struggling. And if you save or you remove the clot, that penumbra will come back and be alive right away. So basically, it is a struggling brain tissue that is thirsty for blood, and it's not dead yet. The core is the already dead tissue. فلما يصير عندك blockage in the MCA, you will start with the center of a core and a surrounding tissue of a penumbra. And with time, this will increase. The core will increase and the penumbra will decrease until you reach the full core. And this process can last up to 24 hours. فمشان هيك إذا بيجيك مريض with this small core and big penumbra, still, if you remove the clot, they will end up with a stroke, but the penumbra will be saved. And the more you do it earlier, the more penumbra you will save. But إذا جاك مريض in this situation, all the brain is core infarct, no reversible tissue. Probably if you do thrombectomy here, there is no benefit. هسه هل هذا الconcept can we pick up on imaging? Yes. And the way to pick it up is by doing a perfusion scan, the CT perfusion. Bottom line, this guideline, this trial looked at patients 6 hours to 24 hours. Still, the patient will come with a stroke, will come with large vessel occlusion, but instead of doing CT angiogram, you have to do a CT perfusion. And basically, the CT perfusion will look at the core and the penumbra. For example, خليني أورجيكم مثلا this case. So this patient came in with left MCA stroke. The CT perfusion, لما تعمل له post processing, بعطيك two numbers. بعطيك الcore volume وبعطيك الperfusion volume. فإذا بتطلع هون, the core is only 23 ml. فيعني this picture at the top is the tissue of the brain that even if you regain revascularization, this tissue will be dead, no matter what. But the tissue in the bottom part of the picture, this is the tissue that you will save if you do mechanical thrombectomy. Nowadays, we look at the core and the mismatch. فبتطرح هاي من هاي. إذا الperfusion mismatch is bigger, the patient is still eligible for reperfusion therapy. I know this is probably very quick summary, but those dawn and diffuse, they look at this. They look at the perfusion and they look at the core compared to the penumbra on CT perfusion. And those studies showed outcome, the dawn and diffuse trial. And in 2018, the American Stroke Association changed the guidelines to extend the window up to 24 hours of the time of onset. هاي بعض الحالات مثلا زي ما حكيت لكم, this is a case the patient had a carotid stenosis and an MC occlusion. This is an MC occlusion. You see here, this is the angiogram. MCA blocked. We go up with our device, and this is the restoration of the blood supply, and this is the clot. This is another case of no core. There's no core infarct, so there is no dead tissue still, and all of the patient deficit is coming from a penumbra. The mismatch volume is very huge, and there is no mismatch ratio, and the mismatch ratio is 0. This is a patient I've done in 2020. كانت عمرها 19 years old, just to give you a heads up. In a patient, they're not always old. They can come in young patient. This patient had a PFO. She had a DVT. كانت على oral contraceptive pills. صار عندها DVT ومع PFO. The clot went to the brain. Patent foramen oval. She was a college student. Came within time. MC occlusion, reperfusion, and the patient went home. Another patient, 45 years old, كانت تشتغل في مصنع وإجت في MC occlusion, and this is post revascularization. This patient is a 77-year-old. Although she's old, she came only with an NIH of 2, only for aphasia. But we took her and look at the M2 occlusion. It's a distal MC occlusion only to the area supplying the language center, and the patient went home with no deficits. Bottom line is stroke treatment for large vessel clot is indicated up to 24 hours with a specific patient population. And those specific patient population is the patient who has a small core, a small dead tissue, and a big penumbra, a big struggling tissue that you can save if you open the blood vessel. Number need to treat is still good. It's 2.5 or 2.6, but still effective. It is one of the effective treatment nowadays for stroke. So in conclusion, neuroendovascular treatment is an evolving treatment for stroke. I do believe in the coming years, we still will do even mechanical thrombectomy beyond 24 hours. Even if you have complete infarct, we still do it. And if some studies coming from Germany, patients who had a complete infarct, no core, all of the stroke is core. If you do mechanical thrombectomy, you can decrease the chances of hemicraniectomy for brain herniation, and the outcome might be better than no thrombectomy. The best outcome possible is with early recognition and quick treatment, and our goal is to increase the community awareness of stroke. If we can do something, عارف إنه resources are limited في البلاد للأسف. But if we can increase the awareness in the community that this is a reversible disease, dealing with the risk factors, treating those risk factors, that will make a big change. I will finish here, and I'm open for questions. تفضل.
بس ما تسأل بس عن الانتي ثيرابي في الاكيوت ايفنت في الستروك وفيما بعد كلونج تيرم، لأن شفت في كثير كونتروفيرسي يعني which drug to use, which dose، ويعني for يعني which duration، إنه في شيء حاطين اللي هو كلوبيدوجري، في شيء أسبرين زائد دايبرتامول، في شيء أسبرين، في شيء بعطي ديول ل 3 weeks، في شيء for 3 months. في كثير
بالضبط هذا السؤال يعني أنت فتحت موضوع يعني بده جزء ساعة زمن بس نحكي عن الريسك فاكتور. بس خليني أحكي لك الرول اوف ثumb. دائما when you pick up، هسه انت بتحكي عن anti platelet therapy، we're not dealing with AFib. لما يكون عندك atrial fibrillation treatment is different، صح؟ هذا شيء ثاني. الchat VAS score is higher. هسه anti platelet therapy، this is my take home message. طبعا في studies، في مليون study على الشغله هاي، بس this is my take home message. إذا look at the risk reduction that you achieve with each medication. خلنا let's brainstorm very quickly. هسه لما واحد يجي عنده stroke not from AFib, not from anything, and you give him aspirin, what is the risk reduction that you achieve with only aspirin? How much percentage you will achieve stroke reduction by giving someone aspirin? 20%, 30% stroke? Give it a guess. خمن، أعطيني تخمينك. إذا مثلا إجاك مريض عنده stroke وأعطيته aspirin، قد إيه أنت راح تقلل احتمالية إنه يصير عنده stroke المرة الجاية؟ 1%. حدا ثاني more optimistic؟ شكله مش optimistic صديقنا هنا. Any other guess؟ So it's up to 15% بس. فأنت لما يجي واحد عندك ستروك وتعطيه أسبرين، أنت قللت احتمالية إنه ينصاب في الستروك المرة الجاية من الأسبرين alone is only 12 to 15%. But what adds up to the risk reduction is the other risk factors. يعني إذا بتعدل الهايبرليبيديميا and you target an LDL less than 70, this is another 20%. If you ask him to exercise, there's another 10 to 20%. If you control the hypertension, so if you add all of these, you can reach up to 85%. هسه إذا إجا مريض هو على أسبرين وصاب ستروك، صح؟ أغلب الناس بيقولوا لك خلينا نحوله لكلوبيدوجرل، صح؟ هسه شو الريسك ريدكشن في كلوبيدوجرل؟ خلينا نفكر. إذا الأسبرين 15%، قد إيه الكلوبيدوجرل؟ أعطيها تخمين، يلا شو مشكلة؟ ببلاش، تخمين ببلاش.
25%.
It is up to 20%, correct. It's up to, فأنت اللي ضفته 5%. بس look what the studies showed. The studies showed you gained 5%, but the risk of hemorrhage increased significantly compared to Plavix, to aspirin. هسا خليني أعطيك multiple scenarios. إذا إجاك مريض على aspirin already من البيت وصاب ستروك، الخيار السؤال راح تسأل نفسك، هل اجى على aspirin and this is a failure of like treatment failure، يعني الاسبرين failed، لانه اذا الاسبرين reduce stroke by 15% ف there is a failure rate of 85%، فممكن ما يسويش شيء في 85%. ف would you declare aspirin as a failure؟ My advice to all of you, look at the other risk factors. فانا من الناس اللي I do all what you mentioned. يعني انا مرات بمشي المريض على aspirin، مرات بحوله على Plavix، مرات بعطيهم اثنين. هسه اذا جاني مريض على aspirin already من البيت وصاب ستروك، بس مثلا ال LDL عنده not controlled، he's still a smoker, he's still not exercising, the blood pressure is not controlled, I would not declare aspirin as a failure لأنه في other risk factor failed. فالbottom line is it's a case by case. الdual antiplatelets helps in one scenario إذا كان عندك significant intracranial atherosclerotic disease. في a big trial called SAMPRIS trial, SAMPRIS، اللي هم هاي الترايل they looked at patients with MCE stenosis more than 50%, and what they did, they tried to go up into the brain and they do the same thing cardiology do، بحطوا stent. وهاي الترايل showed failure إنه if you stent the brain you kill patients. This trial, what we learned from this trial إنه if you do dual antiplatelets the outcome is better than stenting. For those patients, I do dual antiplatelets. بعطي aspirin and Plavix only for 90 days, 3 months. Then the outcome after 90 days, you increase the hemorrhage with no benefits. فإذا بدك تعطي patients dual antiplatelets ما تعطيهوش إياها أكثر من 90 days. If the patient comes in on aspirin, other risk factors already controlled, I will declare aspirin as a failure. I will switch to Plavix. إذا إجى على aspirin والother risk factors not controlled بخليه على aspirin I will control the other risk factors. فما فيش، المشكلة إنه ما فيش guidelines، يعني بجزء أنا I increase your confusion، بس أنت خذها case by case. اعرف هاي الأرقام، أنت 15% with aspirin, clopidogrel or Plavix you go maybe up to 20% with a slight increase in hemorrhage. فيعني what you're gaining. and بعدين عشان نزيد الconfusion تبعكم أكثر، there is also 20% risk of Plavix resistance، صح؟ في ناس بتعطيهم Plavix and the Plavix does not work. فأنت probably you do not do them a favor by switching them to Plavix. يعني إذا إجاك مريض على aspirin ورحت حولت لي على Plavix وهي or she is a Plavix resistant by genetics، فأنت زي اللي أعطيته مي، يعني شلت الأسبرين وأعطيته مي، يعني أنت هسه هيك ضريته أكثر ما فدته. يعني there is multiple reasons for failure. بس يعني all of the above is correct. إذا أنت يعني بدك تكون more careful you can do dual antiplatelets بس no more than 3 months. I do not do it more than 3 months. أنا عارف إنه بجوز كانت كثير عليكم. I'm more open to more topics، يعني إذا بدكم more topics to go through we can do more. إذا بدكم يعني نحكي يوم عن how to manage risk factors of stroke, evidence based. إذا بدكم نحكي عن intracranial hemorrhage, how to treat in acute settings in the ICU, aneurysm and subarachnoid hemorrhage. If you deal with those, we can also talk about vasospasm and treatment in the ICU, like ICU treatment. إذا ما عندكمش أسئلة تفضل.
Thank you.
الله يعطيكم العافية. الله ديروا بالكم على حالكم. سمعت إن الكوفيد عندكم مولع نار. ديروا بالكم على حالكم. الله يرضى عليكم.
شكرا.
سلامات.